Okay, so today we're going to talk about the blind spots on the chest radiographs, so where lesions can hide on chest radiographs. Now, very much when you're dealing with perception, what you see is affected by the context. So a couple optical illusions that I find kind of interesting here. So would you believe that the shades of red of this and this are exactly the same, even though this looks lighter? And it only looks different to your eyes because of the surrounding context. But the actual shades of red are actually the same, but notice how different they look. And then this one, is the red dot on the near corner of the far corner, and it can switch back and forth depending on how much you stare at it and what you imagine. And this one, I often get dizzy looking at this when I try to count how many legs this elephant has, right? So the skin. So the perception is very interesting. So here on this chest radiograph, I mean, we look at it and it looks like there's a lucency here adjacent to the descending thoracic aorta, right? So that looks like a pneumomediastinum. But it's funny, if I cover that edge with this piece of paper, you see that the lucency along that region disappears. So what is it that we're really looking at here? Why do we see this lucent line coming down alongside the descending thoracic aorta? What is that then? That's a Mach effect. So you see that also when you look at, remember on your open mouth views, it always looks like there's a fracture through the odontoid process, right? That's also a Mach effect. So this is kind of an optical illusion. And so the same thing can happen sometimes here alongside the heart border, especially where the pulmonary artery is. So it can look a little bit lucent, and people can mistake that for a pneumomediastinum or pneumopericardium. But you have to realize that. So one of my favorite expressions is you see what you know. So if you realize that that's a Mach effect, then you realize that it's not real. But if you don't, then you might mistake that for a pneumomediastinum. We've discussed this also, the difference between a pneumothorax. You can use the Mach effect to your advantage if you're trying to differentiate between a pneumothorax and a skin fold. So notice that you see the fine white line here, that you have a positive Mach effect, whereas with a skin fold, you get a negative Mach effect. This looks more like a line, this looks more like an edge. So you can use this to help you interpret your chest radiographs. So if I show you this chest radiograph, what's abnormal? Well, what's the glaring abnormality on the chest radiograph? Yeah, so what do you think that is? Well, you're reading this chest radiograph from the ICU and you see that. What are you going to say? What do you think's going on? Is that a pleural effusion? Is that a lung mass? What is it? What are you going to say it is?
It's atelectasis.
So you think it's atelectasis. Is there enough volume loss to say it's atelectasis?
No, but there's something in the right mainstem bronchus.
Yeah. So there's a consolidation there. So what is that in the right main bronchus?
It's like a tooth.
That's a tooth, right? So you can explain all of that, right? So this is a post-obstructive change here, or pneumonia, or from this tooth in the right mainstem bronchus, right? It's easy to overlook this because you see all of these markers that we normally just dismiss, but here there's a glaring abnormality that explains the larger abnormality on the chest radiograph. Now, having seen that, you should have no problem with this chest x-ray. What do you see here? Yeah, there's a tooth in the left main bronchus, right? So this is very easy to overlook because we're not used to seeing these things. So the unexpected finding is also very easily overlooked, even though in retrospect it becomes very obvious. Once somebody points this out to you, you can't help but notice that tooth now, right? That's the only thing you can see pretty much on the chest radiographs. So very much what we do is based on pattern recognition. We learn from our prior experiences, the appearances of abnormalities, and a good radiologist remembers the patterns, and that's what you use to formulate differential diagnosis. But there's also a difference between active and passive observation. This also comes up, remember we're looking at these CT scans, and now we have over 300 images on every CT scan. And as we scroll through these axial images, what tends to happen is we kind of have this unconscious filter. And we scroll through the image and we wait for something to set off the filter, something that sets it off as an abnormality, right? So here you can see that there's a small lung nodule, right? So it's very easy to miss as you're scrolling through this, but you have to be diligent. It's very easy to fall asleep while you're sitting there scrolling through these stacks of images, waiting for something to set off your unconscious or a filter that you can make pretty much unconscious, right? So there's a difference between active and passive observation. So passive observation is when we're scrolling through these stacks of images, just waiting for something to set us off, as opposed to actively looking as we're scrolling through the images, asking ourselves questions about what is it that we're looking for, what is it that we're trying to evaluate. So here, if you look at this, that looks like a spiral pattern, right? But is that really a spiral pattern? What are we looking at there? Yeah, those are concentric circles, and when you look at it passively, it looks like a spiral pattern, but only when you look at it actively, when you actually follow the circles all the way around with your eyes, can you tell that these are concentric circles and not a spiral. But the same thing is true when we're looking at images, right? So you want to sit there and actively ask yourselves questions as you're scrolling through the images. What are you looking at? So here I'm scrolling through the right upper lobe. I'm looking for nodules. Here I'm scrolling through the right lower lobe. Here I'm scrolling through the liver. I'm looking for liver lesions. Now you go back and you scroll through the spleen. So actively looking as you're scrolling through the images, asking yourself these questions about what you're looking for is very important. Otherwise, you're just passively waiting for something to pop up at you. And I've shown this case to you before. What's the abnormality?
Left femoral dislocation.
Yeah, there's dislocated left shoulder. And again, that's very easy to miss unless you have the habit of systematically examining your chest radiographs and going through everything. If you're just sitting there looking for something to pop out at you, this is going to be very easily overlooked. And the phrase that I always hear is nothing jumps out at me when people are looking at the chest radiograph and ask them what's normal. Well, nothing jumps out at me, as if it's the responsibility of the abnormality to announce itself to you, right? You have to go looking for it actively. So that's a left shoulder dislocation, very easy now that you have a combed down view. When you look at this radiograph, most of us don't have a problem making the finding. What's the finding here? Well, hopefully most of us don't have a problem making the finding. Well, that's not the major finding. What? Yeah, the enteric tubes, the NG tubes going into the lung. Now, usually we pick this up right away. Why?
Search patterns first.
Well, that's right, because our habit is usually we've learned that the first thing that you want to look at when you're looking at chest radiographs is the first thing you evaluate is the position of lines and tubes. So we've learned to make that habitual, that's the first thing we're going to look at. So we're not going to miss a misplaced nasogastric tube, although the novice will miss it easily, right, the first time you show them a film like this. But we will not, because we're in the habit of including this first in our search pattern when we're looking at a chest radiograph, okay? So we have a checklist. An active observer has a focused, systematic approach. So for every type of study, you should develop a checklist and a methodology for how you review that and apply that consistently for every type of case that you review. So you should develop your own checklist depending on the type of study that you're reviewing. So as an active observer, you have to have a focused, systematic approach. For every study, every different type of study, you have a checklist and a methodology of how you're going to approach reviewing that study. Now, most of us develop our checklist based on what we've missed in the past. So, first we'll check lines and tubes, and then we'll check the heart, mediastinum. Make pneumothorax is always on your checklist, right? So you go back and you take a second look to make sure there's no pneumothorax. Pneumoperitoneum is on your checklist. You go back and you make sure there's no pneumoperitoneum. The bones are on your checklist, right, for the shoulder dislocation. So all radiologists make mistakes, but a good radiologist does not repeat past mistakes. So a bad radiologist makes the same mistakes over and over. But if you're learning from your mistakes, you're including things in your checklist, and once you habitually include things in your checklist and you routinely apply that on every case, you get faster and faster in terms of how quickly you're interpreting the study. So you could have many things on your checklist, but after a while, from just the practicing of doing it, you can go through all those things very quickly. So if I show you this case, right? So we're looking at this study, and the abnormality is pretty obvious. There's a mass over here, right? You can see it. There it is on the CT. 5 years prior, there's nothing. But there's this chest radiograph was read as normal a year prior, right? So now you look back at this and you notice, oh, wow, there's the lesion. It's really there, right? No question that that's the lesion. This is clearly visible. Is this a mistake? That's an interesting question. Is this a miss, right? Now, that's very difficult to arrive at. I mean, you could say that, so this terminology about lesions visible in retrospect, these are all these kind of terms that people will use rather than a miss lesion. How can you decide if a lesion like this is actually a miss, right? You, as the interpreting radiologist, once you've looked at this film, you're completely contaminated now. You can't evaluate the radiologist who read this film. You know where the answer is. How can you say that this is a mistake or not? So that's a different, very controversial topic. So for subtle lesions like this, it's difficult to say if this should have been picked up or not. So and it gets even worse if I put an arrow on it, right? Now you show this to a jury. Oh my God, how could you miss? There's the arrow. How could you miss that thing, right? So what I'm talking about more are lesions that you should not miss, right? So here, if you don't pick up the abnormality, this I think is an egregious error. So what's the abnormality here? Yeah, there's a left apical mass, right? So if you compare this side to this side, there's all this opacity in the left apex that you have to explain, right? This you should not miss, something like this. So that's the point of what this lecture is about, big mass there, right? So you should not miss something like that. So we want to make sure that you don't. So the objectives for this talk are to learn the blind spots on a chest radiograph and to develop an approach to evaluate them and to avoid the mistakes of the novice. In many respects, of all the lectures you're going to get this year, this is probably the most important one. And you're not going to have a test on this, because your test on this, if you're reading chest radiographs, your test on this is going to be every day in practice. And the penalty for failing that might be a malpractice suit. So I would urge you to pay attention and to apply some kind of systemic methodology when you're reviewing chest radiographs. So a very interesting paper came out in 1992 where they looked at missed lung cancers on chest radiographs and where they tended to occur. And they tend to cluster like this over the upper lobes, especially here, closer to the apices. And then there was a follow-up study that was done in 2009 with many more cases. And you can still see this kind of clustering of where these missed lesions tend to cluster, especially here in the upper lobes, and then here over the hilar regions, closer to the midline. So you want to realize that when you're reading your chest radiographs. So locations of these missed lesions. So what I like to do is to kind of superimpose a pattern like this on a chest radiograph. These are the areas that you want to look at very carefully. So here's a nice little heart here over the upper part of the chest. So this area here, especially in the apices, you want to look at very carefully. Here close to the midline, the mediastinum overlying the hilum, Lesions can easily hide behind the heart, so these areas too you have to look at carefully. Usually lesions that are out here that are surrounded by lung parenchyma are easily spotted, so those tend not to be lesions that you're going to overlook. These are the areas that you have to pay careful attention to. So the right paratracheal line, the arch, the EP window, the hyla, the mediastinal lines, the azigoesophageal line, the paravertebral line, retrocardiac region, the areas over the diaphragm, all of these things should be in your active checklist as you're reviewing a chest radiograph, looking at these particular areas because these are areas where lesions are easily overlooked, okay? So up here, when you're looking up here, you want to look for symmetry as you compare one side to the other, all right? So if I show you this case, what do you notice? Yeah, so if we look for symmetry, we notice right away that there's an opacity here that is not here. So there's an abnormality here. And the other thing that I like to say is remember that the blackness of the lungs should go out to the edge of the ribs, right? That's true everywhere. And if it doesn't, you have to explain it. Over here, if that happens, it's going to be a pleural effusion. Over here, it might be a pleural mass, right? Up here in the apices, you could have pleural thickening or you could have a mass in the apex. You want the blackness of the lungs to go out to the edge of the ribs. And if it doesn't, you want to look for an explanation of that, okay? So there's an apical tumor there. There's a lung cancer here in the right apex. So if I show you this, what do you notice? Nothing? Yeah, again, it's a little bit more subtle than the last case, but you do notice that there is some difference in the symmetry between this side and this side. So there's something here that's making this area a little bit more dense than the other area. That's another tumor. Right? Well, they always look so much worse on the CT than they look like on the chest, right? But there it is. There's another cancer there in the right upper lobe. So now you should be really good at doing this game. Yeah, no problem now, right? Right? So there's a real difference between this and this. Something's there. 4 years prior, and this is really helpful, right? A lot of times we come across these, we question these opacities, whether they're real or not. But the prior study is really, really helpful. So what tends to happen, in my experience is not so much that I look here and then I look here and, ooh, there's something here, is that while I'm reviewing the chest radiograph, gee, there's something that looks a little bit different over here than it does over here. And now you go back to the prior study and you look, wow, this really looks very different than the way it did before, right? So now your index of suspicion is a lot higher than what you're dealing with here is a real abnormality. So using those prior films is very helpful, and yeah. I've only come across 2 cases where the lordotic view was actually helpful, and this is one of them, right? So lordotic view here, and it makes it a lot more obvious that there's a mass now in the right apex, okay? What about this case? We see anything that you would question? Okay, so you're wondering about something over here, right? Again, 2 years prior. Now when you compare, what happens to your index of suspicion? Yeah. So now, boy, this really looks a lot different now than it looked before, okay? And there's a tumor there, okay? In the left upper lobe. What about this case? The most subtle of all of them. Now, as the cases get, more and more solid, it's going to be hard to say whether, everybody should definitely pick up the abnormality, but do you see something here? So, yeah. So maybe over here, there's something that looks a little bit different, right? But that's really subtle here, right? Well, the Student's tumor tends to be more anterior, right? The Student's tumor is at the costochondral junction, okay? There's a tumor there, right? Really subtle, okay? But now you guys gotten so good at finding these. Here, no?
Right upper lobe medially?
So you think it's right upper lobe medially? How about it? Oh, let's be fair. Let's look at the close-up. Yeah, so there's a little bit of increased opacity there in the left upper lobe. There's a tumor there. Okay. Now, this one was not picked up prospectively, but just to show you how subtle this can be. Okay. All right. The right paratracheal line belongs in your checklist. You definitely want to look at that, right? On a good PA chest X-ray, you can see the right paratracheal line through the shadow of the superior vena cava. And we see it because there's air in the trachea, there's air in the right upper lobe, there's your right paratracheal line, okay? So your right paratracheal line, you want to be used to looking for that. Here, when you look at this chest radiograph, right, you might wonder a little bit. I don't see a good right paratracheal line. There seems to be some increased density there. And again, now you go back and you look at the old film, and can you appreciate the difference? Yeah, you can. You can really see a nice right paratracheal line here, but now that looks like there's all this added opacity there in the right paratracheal region. That's lymphadenopathy, as it turns out. Right? This is right paratracheal lymphadenopathy. So there's another case. Again, I don't see a good right paratracheal line. Looks like there's some added opacity there in the right paratracheal region. We go back to the prior study. Looks like there's increased opacity comparing this one to this one in the right paratracheal region. There's a tumor here that's extending into the mediastinum in the right paratracheal region, causing all of this. This one, right, again, we look at the right paratracheal region, yeah, it looks like there's actually something bulging out from there in the right paratracheal region. See? Lymphadenopathy, tumor. Okay. There's a tumor there in the bronchus and paratracheal lymphadenopathy. This one, again, increased opacity in the right paratracheal region, and the patient also has some emphysema. And so with subtle abnormalities, if there's emphysema and we're talking about lung cancer, that also kind of increases your index of suspicion. You compare to 2 years prior, not quite as dense in the right paratracheal area. Look at the size of this tumor. It's invading now the vertebral body there. And that's what's projecting over the right paratracheal region in this patient. The aortic knob in the left paratracheal region. So the aortic knob, descending thoracic aorta, this on a good PA chest X-ray, this should be pretty distinct, right? So this should be fairly well outlined. So you look at this, what do you notice? Yeah, so something funny about the contour of the aortic knob. There's some increased opacity up here. Things look really fuzzy over here. There's not a sharp aortic knob. Okay? Look at the prior. What happens to your index of suspicion now? Yeah. So this is really much different than the way it looked before. So something's going on here, right? Tumor with AP window lymphadenopathy. Okay. What about this? So next to the aortic knob, there's some opacity here. Prior chest radiograph looks very different compared to that. Tumor. Okay. The AP window. We talked about the AP window. Normally it's straight or concave going in towards the mediastinum. So the undersurface of the aortic arch, left pulmonary artery, there should be nothing bulging out from the aortopulmonary window. This belongs on your checklist. You look at the AP window to make sure that nothing is bulging out from the AP window. So we have fat in here, right? There's the aorta, there's the pulmonary artery. See how it goes in towards the mediastinum. So that's the normal appearance of the aortopulmonary window, right? So we talked about that in our very first lecture. And we talked about why it looks that way, so we don't need to go through that. But if there's something bulging out, usually it's lymphadenopathy, right? So this is lymphadenopathy causing bulging in the aortopulmonary window. So this belongs on your checklist. So when we compare this X-ray to the prior chest radiograph, what do we notice? Sure. Here's a very nice AP window. Look over here. There's some soft tissue now with a contour extending out from the aortopulmonary window. Prior chest X-ray, current chest X-ray. It's subtle, but it belongs on your checklist of things that you look at. Lymphadenopathy, the patient has a squamous cell cancer in the left upper lobe bronchus here with AP window lymphadenopathy. That's what this is. The hyla should be vascular and smooth, okay? So there should be nothing bulging out from the hyla. Now you look at this, and you say what?
There's one in the hyla.
Where?
Mostly on the right hyla.
Not on the right, no. Did anybody see it?
Left-hylar opacity
Where? What side?
on the left side.
Right here. You see that? So vessels should be smooth. You see how smooth those vessels are? Nothing's bulging, but you've got something round over here that's obscuring the vessels. Something is obscuring the vessels there. Okay? Here's a close-up. There's a mass here. 6 months later, it's a big tumor. Okay. How about this one?
Left-hylar opacity causing pulling on the radiographs toward it.
The left hilar opacity?
Thought so, because I think you're saying the right side is pushing on the other side.
I'm not going to say. The patient's going to tell you. Do you guys see it or not?
Right hyla opacity.
Right hilar opacity. Look at this over here. See that? Big round thing over the pulmonary artery on the right side. All right? And again, you know, there are things on a chest radiograph that might increase your index of suspicion, right? What might increase your index of suspicion on the chest radiograph when you look at this guy?
Emphysema.
Yeah, looks like there's emphysema, some hyperinflation, maybe a smoker, right? So now you're really worried. So 5 years prior, see how much more obvious it is now when you compare with the prior chest radiograph. That's what the hilum should look like in this patient. There's something there. And that was a cancer. There it is on the CT. Okay? And you can see the emphysema. So again, hyperinflation on a chest radiograph should increase your index of suspicion because it might imply the patient's a smoker. So you have to be careful. You have to, of course, the likelihood of cancer is higher in those patients. We get a little bit more subtle. What about this? Would you read this as a normal chest radiograph, or is there anything that bothers you?
Is there a donut?
Yeah, you might wonder about a donut on the lateral view, right? So that's one thing. What about on the frontal view?
Bilateral.
The the hyla look full bilaterally, right? So you notice that they look a little bit bigger than you're used to looking at, right? Do you see anything bulging out from the hyla? Yes or no? No? Right here.
Yes.
See that? There is something bulging out. These hyla are too. What do you think this patient's problem was? This is sarcoid, right? This is a case of sarcoid with subtle hylar lymphadenopathy, right? See this bulging? That's not normal. So this patient has bilateral hylar nodes from sarcoid. We talked about the infrahylar window, right? That should be a relatively clear area, so the bite out of the donut. So we talked about that before. We discussed that. That's the infrahylar window. Another patient with bilateral full hyla, you might wonder about the right paratracheal line. This was another patient with sarcoid. But if you're wondering, if you're questioning those abnormalities on the frontal view, well, on the lateral view, you have a clear donut here, right? So this patient definitely has something wrong in the subcarinal region, subcarinal lymphadenopathy. So now your index of suspicion of calling the hylar and right paratracheal adenopathy, you're not going to have any problems with. For that chest radiograph, here's the CT, right paratracheal nodes, subcarinal nodes, and some hylar nodes too in this patient, but nice donut sign. So you don't want to miss that on the lateral chest radiograph. What about this case? Yeah, sure. Left hylar, right? So you have this bulging here at the left hylar. A nice donut there. There's a bulging at the left hylar. Okay? Mass here on the CT. The mediastinal lines, right? We've gone through the mediastinal lines. So here's 3 months prior. Here's the current chest radiograph. Any mediastinal lines bother you in this patient? Well, what is this guy? That's the aorta, right? So that's not the left paravertebral line. What is this line? No. The azygoesophageal line is more medial, right? This line is what? That's the right paravertebral line. Now what happens when you look for that on the current chest radiograph? Here it is here, right? So where's the mass? What compartment? Posterior mediastinum. There's a posterior mediastinal mass here. There's displacement of the right paravertebral line. Okay? There's a mass here. Turns out to be retrocoronal lymphadenopathy in this patient. Okay? The heart and the diaphragm are blind spots too. You want to look at the heart and the diaphragms carefully. Anybody see anything here?
There's a spine sign on the lateral radiograph.
I'm not so sure about that. Anything else? No? What is this guy? This guy is the left diaphragm. What is this guy?
Right diaphragm.
What's this big round thing over here? That's a lung cancer. See how big it is? There's a big tumor right there over the right diaphragm. It's a 4-centimeter mass. Very easy to overlook unless you're careful about the diaphragms. CT makes you look so bad. Right? This guy? Yeah, this is pretty subtle, retrocardiac. But again, when we look at the prior, there's the retrocardiac region. Here's the retrocardiac region now. Okay? Tumor. This one? Even harder.
Tiny nodulars, lateral to left ventricle.
Yeah, there's a little nodule there. See it? There it is. The lateral view, sometimes you might see something on the lateral view that you don't necessarily see on the frontal view. So you want to look, of course, you want to look at that carefully, right? There's a nodule here that is not obvious on the frontal view, but we can see it on the lateral view there, projecting over the heart, the lateral view. All right. The neural foramina, the spine sign, you want to make sure that back here, things are clear. You want to look for both diaphragms on the lateral view. You want to make sure that the neural foramina are clear, right? So there's an obvious mass on the frontal view. On the lateral view, you can see where it is. It's posterior. You can see when you look at these neural foramina, look for the spine sign that this neural foramina here is much denser than these guys. So here's where the mass is, right there. Okay, there's the tumor. Another example, don't see anything really on the frontal view, maybe something back there, but on the lateral view, you look at this neural foramina compared to these guys, there's something here, right? Compared to the ones above and below. There's a mass here, there's a tumor there, in the left lower lobe. So here it is. This one, obvious abnormality here on the frontal view. On the lateral view, where is it? Well, look at this neural foramina compared to these guys, right? This one is denser, so it's back here. There's the tumor, in the paravertebral region. So look at the neural foramina, and you can find the tumor on the lateral view too. This one, even more subtle. Very subtle opacity back here, making this neural foramina denser than these guys. 4 years prior, looked normal compared to what it looks like now. Tumor. So I call that the opaque neural foramina sign. You have to be careful because sometimes if a patient has degenerative disease, you can have osteophytes that will also project over the neural foramina. Usually you can tell they're osteophytes on the frontal view. The patient might have some osteophytes that you can see. So osteophytes can also project over that. So you have to, make sure that you're not mistaking osteophytes for lung nodules. So you have to be careful about that too. So in summary, these are the areas you want to pay close attention to. This part up here, you want to look for symmetry, right paratracheal line, look at the aortic arch, the AP window, asiloesophageal line, paravertebral line, the diaphragms, the retrocardiac region. It's important to develop an organized scan pattern when you're looking at the chest. Develop a scan pattern that you use and use the same one. I would advise you to use the same one on all your x-rays. So you get used to it, you get used to looking at all parts of the radiograph, and you'll be able to do it much faster than when you practice it. So if you have the same scan pattern that you use, whatever it is, whatever you want to look at, just develop one, so you're looking at all parts of the radiograph and you've developed the checklist. You want to look at the blind zones that we've covered, the apices, the hilar, retrocardiac region, diaphragms. We talked about the mediastinal lines. The lateral view, donuts, bagel sign, posterior costophrenic angles. Look for both diaphragms. Always look for both diaphragms on the lateral view, posteriorly. If one of them is missing, you have to try to explain that. And then we talked about looking at the neuroforamina. The infrahilar window, we've talked about that, so we want to look for that. And then look over the spine on the lateral view, looking at the neuroforamina, and then looking at the posterior surface of the diaphragms and the posterior costophrenic angles. Those are the blind spots that you want to make sure to include in your checklist for your chest radiograph. So, let's see how well you guys do. Anything on this?
There's a left apical opacity.
Yeah, wow, no problem now. There it is, right? There's your left apical mass. 16 months prior, it was actually there a little bit smaller than it was there. But there's a tumor there, left upper lobe with a nodule, okay? This one, well, that one's a lot higher, harder. So let's look at prior studies. 10 months prior, 3 years prior. What do you notice? Nothing else?
The right paratracheal.
Right paratracheal stripe looks maybe a little bit more density, but is there anything else that's even worse than that? The aortic knob. Look at the knob here. Look at it here, and what happens now? So where's the mass? It's growing there in the left upper lobe. Okay, it's a big tumor there in the left upper lobe. Now that's what was obscuring the aortic knob. Okay. This one, gosh, should have no problems with that one. Notice anything on the lateral view?
Right paratracheal, subchondral lymphadenopathy.
There's a nice donut sign, right? Nice donut sign here. See all that stuff? So, big subcarinal mass. That was a bronchogenic cyst. You don't really see that on the frontal view, but we pick it up better on the lateral view because of the donut sign in this case. Okay? This one? So you're worried about this? Anything else you're worried about? AP window, look at that, right? You don't want to miss that, right? So if you're wondering if this is real or if you should worry on this case, of course, it's a metaport, which kind of gives away the game, but AP window, there's bulging in the AP window, there's lymphadenopathy there. Okay, so it's AP window lymphadenopathy in this patient. Also, you see the PET scan there, okay? This one?
There's an opacity over the neuroforamina.
Yeah, there's a spine sign here, right? See how it gets denser? And there's opacity here over the neuroforamina compared to the ones above. So there's something wrong down here. You really don't see it well on the frontal view at all, right? 8 months prior, looked okay. Certainly did not look like that. 2 months later, big mass that's growing there, okay? Big tumor, and that's what's causing the opacity over the neuroforamina. Okay, so where's the lesion hiding on the first x-ray that I showed you guys at the very beginning?
Capacity behind the ICD.
Yeah, right there behind the pacemaker. There's a nodule. See? So, happy hunting. Hopefully you'll apply this. All right, so